Cerebrospinal fluid is analyzed for several conditions. These include meningitis, encephalitis, syphilis, brain abscess or tumor, intracranial hemorrhage, and central nervous system involvement in leukemia or lymphoma. Normal cerebrospinal fluid is clear and colorless. If the fluid shows xanthochromia, meaning a pink, orange, or yellow coloration of the supernatant, this is usually due to hemoglobin breakdown products. It is especially important to distinguish between an intracranial hemorrhage and a traumatic lumbar puncture. The normal protein concentration is between 15 and 45 milligrams per deciliter. Glucose levels are typically 60 to 70% of plasma glucose. The normal white blood cell count is 0 to 5 per microliter. Differential counts usually show 70% lymphocytes and 30% monocytes. Electrophoresis of cerebrospinal fluid can reveal oligoclonal banding, which is characteristic of multiple sclerosis. In such cases, glucose levels are often decreased and protein levels are increased. The first cerebrospinal fluid tube is sent to chemistry or serology. Common tests include protein, glucose, lactate, VDRL, and latex agglutination tests. The second tube is reserved for microbiology. This tube is used for gram stain, culture, and India ink preparation. The third tube goes to hematology. It is used for cell count and differential analysis. In a hemorrhage, all cerebrospinal fluid tubes appear equally red or bloody. In contrast, with a traumatic tap, you see progressive clearing of blood in subsequent tubes. When a hemorrhage is present, the supernatant becomes xanthochromic, meaning it has a yellowish discoloration. In a traumatic tap, the supernatant remains clear. In true hemorrhage, no clots are present because the blood has already lost its fibrinogen. In traumatic taps, however, clots can form because fibrinogen is still present in the introduced blood. In bacterial meningitis, protein levels in cerebrospinal fluid are increased. Glucose levels are decreased because bacteria consume glucose. The predominant white blood cells are neutrophils. Lactate levels are also elevated. In viral meningitis, protein levels are only slightly increased while glucose remains normal. The white blood cell population is predominantly lymphocytes. Lactate levels stay within the normal range. In fungal meningitis, protein levels are increased. Glucose levels can be normal or decreased. The white blood cell population consists mainly of lymphocytes and monocytes. Lactate levels are elevated. The formula for manual cell calculation is the number of cells counted multiplied by the dilution, divided by the number of squares counted multiplied by the depth of the chamber, which is usually 0.1 millimeter. The term cells counted refers to the number of cells observed under the microscope. Dilution is the factor applied if the specimen was diluted before counting. Squares counted refers to the number of hemocytometer squares used for the measurement. Depth is the chamber depth, which is standard at 0.1 millimeter. This formula is applied when analyzing cerebrospinal fluid, synovial fluid, and serous fluids. It provides a standardized method for determining accurate cell counts and ensures both reproducibility and diagnostic reliability. Semen analysis is most commonly performed to evaluate infertility. It may also be done after a vasectomy to confirm surgical success, or in forensic medicine where the presence of acid phosphatase confirms semen in alleged rape cases. Additionally, flavin in semen can fluoresce under ultraviolet light on clothing. Reference ranges are important for interpretation. Normal semen volume is around 2.5 milliliters. The sperm count ranges between 20 to 250 million per milliliter. Motility should exceed 50%, while morphology should show fewer than 30% abnormal forms. Viability should be greater than 75% live sperm. Absence of sperm is called azoospermia, while a count below 20 million per milliliter is termed oligospermia. Synovial fluid is analyzed for several reasons, including suspected sepsis, hemorrhage, or crystal-induced inflammation. Normally, synovial fluid is clear and pale yellow. The presence of monosodium urate crystals indicates gout, while calcium pyrophosphate crystals suggest pseudogout. Using compensated polarization, calcium pyrophosphate appears blue when parallel to the compensator and yellow when perpendicular. Conversely, monosodium urate crystals appear yellow when parallel and blue when perpendicular. Normal cell counts in synovial fluid are fewer than 200 white blood cells per microliter and fewer than 2,000 red blood cells per microliter. Serous fluids are typically examined in cases of sepsis, malignancy, or systemic diseases. In pleural, pericardial, and peritoneal fluids, effusion refers to the pathological buildup of fluid in the body cavity. The cell count and differential are performed in the same manner as cerebrospinal fluid. Transudates are typically colorless, clear, and watery. In contrast, exudates may appear yellow-white with inflammation, red-brown in cases of hemorrhage, yellow-brown when bilirubin is present, or milky green with chylous fluid. Exudates are usually cloudy and viscous. Transudates have a specific gravity less than 1.015 and protein levels less than 3 grams per deciliter. Exudates, on the other hand, have a specific gravity greater than 1.015 and protein levels above 3 grams per deciliter. In transudates, lactic dehydrogenase levels are below 200 international units, and the cell count is fewer than 1,000 cells per microliter. Exudates show lactic dehydrogenase levels above 200 international units and cell counts greater than 1,000 per microliter. Transudates are most commonly associated with congestive heart failure and changes in hydrostatic pressure. Exudates are linked to infections and malignancies. Amniotic fluid is analyzed primarily to assess fetal well-being and fetal lung maturity. One of the most important fetal lung maturity tests is the lecithin to sphingomyelin ratio. This measures phospholipids in the amniotic fluid. When the ratio is 2.0 or higher, fetal lungs are usually mature. However, in diabetic mothers, phosphatidylglycerol must also be present to confirm maturity. Another marker is phosphatidylglycerol itself. It is a lipid component of pulmonary surfactants. It is not typically detected until around 35 weeks of gestation, and while its absence does not rule out maturity, its presence is highly significant. Lamellar body counts are another useful test. These bodies are secreted into the alveolar lumen between 20 and 24 weeks of gestation. Amniotic fluid is analyzed on automated instruments using platelet counts. This method requires only a small sample volume, has a short turnaround time, is low cost, and is easy to interpret. The foam stability index is a rapid test that can also be used. Other important amniotic fluid tests include alpha-fetoprotein, which is elevated in neural tube disorders such as spina bifida, and bilirubin levels, which provide a reliable estimate of fetal red cell destruction due to maternal antibodies. Sweat testing is used to confirm cystic fibrosis. In this condition, sweat electrolytes such as sodium and chloride are elevated. In body fluid analysis, it is essential to differentiate benign tissue cells from malignant cells. This is critical for the accurate diagnosis of cancers that may present with abnormal cells in effusions. Benign cells usually have clearly distinguishable borders and tend to form flat clusters with visible windows between them. Malignant cells, on the other hand, often have poorly defined borders. They may form ball-like spherical clusters and sometimes even show cells within cells, a phenomenon known as cannibalism. Benign cells can be large, but they are generally uniform in size. They display a low nuclear to cytoplasmic ratio, and their nuclear membranes appear smooth and clear. Malignant cells are often bizarre and non-uniform. They typically have a high nuclear to cytoplasmic ratio, and their nuclear membranes are irregular. In benign cells, chromatin is evenly distributed. These cells may occasionally be multinucleated, but when they are, the nuclei are uniform. Malignant cells differ by showing uneven chromatin and multinucleated forms with nuclei that vary greatly in size. The nuclei of benign cells are generally round or oval, even in structure, without clefts, and they may sometimes contain vacuoles. Malignant cells display nuclear molding, where nuclei press against each other, creating a mosaic appearance. They may also have nuclear clefts, and their nuclei can be vacuolated with clear borders.